Well, what's fascinating about the FALCON trial, it really was a bold attempt to really identify patients who were really completely endocrine naive. These are patients who had not gotten adjuvant endocrine therapy and went on to develop metastatic disease, either because of the point in time at which they were diagnosed, which means that many of them were quite some time ago when they were diagnosed with early stage disease, or just didn't get any adjuvant endocrine therapy for whatever reason. So it really is such a pristine environment of ER-positive metastatic disease to be able to look at. And if I know Matt Ellis, I'm sure that they have lots of correlative work that's going to come out of that study in the ensuing years and will really help us understand the issues of de novo endocrine resistance versus secondary endocrine resistance after being on some kind of anti-hormonal therapy. Is it practice changing in saying that everybody ought to get fulvestrant first rather than the aromatase inhibitor? Not necessarily on the basis of the data from the study, given the characteristics of the patient population enrolled, but given that most patients get an aromatase inhibitor now, even those patients who have high-risk premenopausal breast cancer, in light of the SOFT and TEXT data, a lot of them are getting an aromatase inhibitor now as well. So most of the patients who are developing recurrent ER-positive breast cancer are almost certainly going to have seen an aromatase inhibitor in the vast majority of cases in the adjuvant setting. So I think SERDs are going to be the go-to agent, and combining them with the appropriate targeted therapy is going to be what we're going to be working through.